All right. I think we're going to go ahead and get started now. Welcome to this session of the 2024 Culture of Data Conference. Thank you all again for joining us. I'm Wavine Gongo, she, her pronouns, and I will be moderating this session. We also have Sam Gary, he, him, who is managing the Zoom and making sure that the tech is running smoothly. So you are all should be muted now. We will open up at the end for questions. And so feel free to get off mute then and drop your questions in the chat in the meanwhile, if you have any, as you listen to this wonderful presentation. And if you're comfortable doing so, please add your pronouns to your Zoom name by clicking on the three dots on your video square and selecting rename so we may properly address you. So we have one presentation during this session. They will be presenting for about 25 minutes, followed up with 10 minutes of Q&A, as I've mentioned. I will now turn it over to our esteemed speakers and some of my most favorite colleagues and coworkers from Colorado Access, Micah Gans, Lauren Ratliff, and Sarah Thomas. We have the privilege of hearing from these individuals who are dedicated to advancing healthcare quality and promoting racial equity in data. And it's truly commendable. I am personally excited to hear about the impactful work that they've done, and I'm proud to be a part of a company that prioritizes excellence and equity in healthcare delivery. So let's give a warm virtual round of applause to Micah, Lauren, and Sarah as they share their presentation with us today.
Thank you, Wavine. That was lovely. And hi, everyone. Thanks for joining. So I'll jump right in. Today, we're going to explore the significance of acknowledging and respecting cultural, racial, and ethnic identity in surveys and enrollment forms. What could that look like, and how improved identification could really contribute to promoting social justice in healthcare settings. My name is Lauren, and I'm presenting today with my colleagues, Micah and Sarah. We are part of the Quality Improvement Department at Colorado Access, like Wavine mentioned. Here is an agenda to kind of outline what we have in store. So we'll just introduce ourselves, provide some context to set the stage, delve into the nuances of common enrollment forms, discuss findings from a survey that we conducted, and then wrap up with recommendations. If you've never heard of us, Colorado Access is a nonprofit that serves members of Health First Colorado, which is Colorado's Medicaid program, and Child Health Plan Plus health plans, which is commonly referred to as CHIP. And while we are a health plan, we feel like we're really positioned at the crossroads of public health and clinical outcomes, and we aim to create and advocate for access to quality, equitable, and affordable care. Our membership base is pretty diverse. It encompasses around 522,000 people residing in Colorado. It's broad. It includes refugees, immigrants, foster care children, and more. Just a note before we get into the content, we typically call patients members in case that verbiage is confusing. I want to take a moment to acknowledge that we speak from a place of privilege today and understand the weight of responsibility that carries. We really aim to approach this with humility, empathy, and a real dedication to fostering diversity, equity, and inclusion. And with that being said, we genuinely welcome any feedback on how this presentation lands for you. So that brings us to our first learning objective. We will analyze traditional intake forms in effectively portraying racial and ethnic identity, and then explore ramifications for healthcare outcomes. Let's take a moment and define some terms before we get into content. So to start, our presentation is really rooted in the understanding that race is a social construct. It's historically utilized to distinguish between groups based on physical attributes alone. It's a product of societal perceptions, and racial categories can vary across different cultures and really evolve over time. Throughout history, race has been associated with discrimination and social hierarchy, social stratification, which involves categorizing people into socioeconomic tiers based on factors like wealth, income, education, and power have been intertwined with race, which has contributed to historical inequity and institutional bias. Let's move on and define ethnicity. So ethnicity pertains really to the cultural, social, or national connections that folks or groups align with, often stemming from shared features like language, religion, customs, traditions, and lineage. Unlike race, which focuses mostly on physical traits, ethnicity encompasses a broader spectrum of cultural elements as well. It can be self-identified or attributed by others. Ethnicity influences individual and collective identity, as well as interpersonal dynamics. And like race, ethnicity is socially constructed and exhibits significant variation across diverse societies and settings. So, the key point here is just that race and ethnicity shouldn't be conflated with genetic ancestry. The rationale for our discussion stems from the historical tendency within the medical community to attribute health outcomes and diseases solely to physical appearance, while neglecting the impact of institutional and structural bias and racism that really contribute to the health disparities. It's really important here to approach the interpretation of health outcomes cautiously, and we want to avoid any unfounded assumption. Conversations involving race and ethnicity require sensitivity to prevent the reinforcement of stereotypes, the perpetuation of discrimination, and really to acknowledge the underlying social determinants of health at play. So let's explore some typical forms our members may encounter. Let's look at the 2020 census form first. So notice the box here on the left. It distinguishes Hispanic origin from racial categories. There's a section for Hispanic, Latino, or Spanish origin with further details provided there. And then on the right, individuals can write in their race with examples and expanded Asian categories offered. Here is another example of the Health First Colorado, which is the Medicaid application. So they have 16 choices, including other for race, and it's an optional question for everyone. Lastly, this is the CAP survey. This just stands for Consumer Assessment of Healthcare Providers and Systems Survey. It's just a national survey that many Medicaid plans administer. It's a federal requirement for most. It includes 8 options for race and ethnicity. And so it's evident from these 3 forms, the way race and ethnicity identity is asked is really varied, and most forms lack standardization. So, after observing the wide variation, it's really important to note limitations that are inherent in common identity categorization. These limitations are not specific to the forms that we've just presented, but are more general in nature. For instance, a singular Asian category may not adequately capture the diverse subcategories within the Asian American population, such as Vietnamese, Korean, Malaysian, etc. Many individuals identify with multiple racial or ethnic backgrounds, and categorizing someone into just one group can result in inaccurate representation. While health outcomes and risk factors are often linked to socio-demographic variables, which include race and ethnicity, relying solely on these categories can really oversimplify complex health disparities. So an oversimplification runs the risk of perpetuating stereotypes, institutional bias, and racism, underscoring the importance of seeing each individual as they deserve to be seen. We mention this not to make collecting demographic data even more complicated, but really just to talk through potential limitations that we all should be thinking about. And with that, I will pass it to Sarah to dive into the data, the fun part.
Thanks, Lauren. So our second objective today is to analyze some of our internal member survey data and explore how effective collection and utilization of data can contribute to addressing broader societal challenges and improving public services and outcomes. So today we're going to talk about our internal Colorado Access survey data that we have collected from our members. So what is the Colorado Access Member Survey? It's a survey that we administer twice a year through our customer service team. Our customer service team asks these survey questions verbally to willing members who have called in for assistance. So we use this method to gain real-time feedback from members to better understand their experience, act on their response in real time, and then design improvement projects based on their feedback. Survey questions are developed with influence from a lot of different sources that are listed here. So our member advisory council, which is a monthly meeting that we have with members, and we get help from our members in that meeting to help design survey questions. We utilize CAP survey results, which Lauren spoke to a bit earlier. We listen to anecdotal feedback from our members. We host internal focus groups with staff, such as our customer service and our care management teams, who regularly interface with our members. We have also hosted a member survey summit, or just a meeting, which we typically do a few months after a survey closes. And we'll invite both members and member-facing staff to discuss our survey results, but then they'll also help us decide on survey questions for the next round of surveys. And so all of these different approaches help us to determine survey questions. And then the team asks this survey on all member phone calls until the goal of 500 surveys is met. So our survey data was collected from March through June of 2023. These were the survey questions that we asked. What is the number one thing Colorado Access can do so that you have a better experience as a Health First Colorado or CHIP member? So this is a question that we ask on every member survey because our primary goal is to gather actionable feedback for designing improvement projects that could significantly impact the member experience. So this question also enables us to track and compare trends across surveys. And then the following two questions are exploratory or curiosity questions. So we don't typically ask these on every survey, but what they are: what ethnic, racial, or cultural identity best describes you? So we designed this question with the intention to encourage members to self-describe their race and ethnicity in a non-traditional manner with the aim to foster deeper exploration of identity. And then that third question: how does your ethnic, racial, or cultural identity affect your healthcare? This question was chosen by members of our member advisory council, and they were very enthusiastic about incorporating this question into the survey. So we were super excited about that. And then you'll notice this fourth question at the bottom. So this was actually intended for our customer service team to document. So we didn't ask this to members, and this was just were referral options offered by the customer service team during the phone call. So this question is included in every survey for the customer service team to document their actions during the call. So it enables us to track the resources or referrals provided to members, if any, during the survey. All right, and here are the demographics for the member survey. We had 529 survey responses, and the majority of the survey participants skewed female, and this is pretty typical of our surveys. And then in regards to age, the majority of survey participants were between the ages of 20 and 45, so 35%, followed closely by the 10 to 19 age group, 23%, and then the 0 to 9 age group at 21%. As we mentioned earlier, we do manage care for our Child Health Plan Plus or our CHIP members, and we'll see an uptick in parents calling with questions for their kids, so that's why our data will typically skew a bit younger. All right, so we're going to dive into the heart of our presentation today. So following the closure of the member survey, we went back to our internal data and we looked at what those 529 members initially provided for race and ethnicity when they first enrolled in either Health First Colorado or the CHIP Health Plan. So here's the breakdown of our internal data for those 529 surveyed members. 35% selected white, 33% selected Hispanic or Latino, 20% either chose other or left it blank, 7% enrolled as Black or African American, 2% enrolled as Asian, 1% identified as 2 or more races, and then less than 1% identified as American Indian or Alaska Native, Native Hawaiian or other Pacific Islander, Asian or Pacific Islander and Hispanic or Latino, or American Indian or Alaska Native and Hispanic or Latino. And we've circled in red the other unknown in the 2+ races categories. Particularly, the other unknown category is notably large, which indicates a limitation within our data set. Okay, so what did those 529 members answer when we asked through our member survey question, what ethnic, racial, or cultural identity best describes you? We identified 46 unique categories when survey respondents were asked to define their racial, ethnic, or cultural identity. And you can see the amount of variety in this word cloud. And it's interesting that when you give people the ability to describe their identity in their own terms, it goes beyond those 13 categories that people had as options upon enrolling in Health First Colorado or Medicaid. So most participants did respond to this question. In total, we only had 12 people refuse. All right, so diving deeper into that comparison between our member enrollment data and survey data, we discovered that 36% of surveyed members did not match the race and ethnicity listed when they initially enrolled in Health First Colorado or CHIP. So hence, when we mention a 36% discrepancy between the two, this is what we're referring to. And then these graphs really show the differences between the two data sets. So on the left, we have the Health First Colorado enrollment data, and on the right, we have our member survey data. And you can immediately notice that stark contrast between the two. The right graph is rich with color and detailed descriptions, showcasing the diversity of self-identification. And then in contrast, the left graph is much more limited, which underscores the differences observed when individuals are given the opportunity to self-identify. So this was our last survey question asking, how does your ethnic, racial, or cultural identity affect your healthcare? 83% of respondents said it did not affect their healthcare, with 11% of the survey population saying that it did. So we want to keep in mind that there is, of course, limitations to both of these survey questions. Answering questions like this may feel pretty personal or uncomfortable, and there's always going to be an inherent power dynamic between a member and the organization that's providing healthcare for that member. So just read these results with that in mind. We included some quotes from some of the survey respondents on the right in the blue box. So I'll just mention a couple here. The second one, hard time finding providers in my area that understand my cultural and racial background. So someone else noticing they're feeling judged based on their culture and dismissal of their health concerns. And then the last one notes that in Colorado, there's not as many Asian providers. And with that, I'm going to pass it to Micah.
Thank you, Sarah. Hello. So our third and last objective today is to assess the significance of enabling individuals to self-report their identities as a method of fostering authentic representation, avoiding stereotypes, and contributing to a more inclusive healthcare environment. So accurate population identification has significant benefits. It ensures that interventions effectively reach the right people. So as we're all aware, maternal mortality rates in the United States have been a concerning issue, especially among BIPOC populations. The US ranks higher than any other developed countries for maternal death rates, with people of color hit hardest. In Colorado, this is especially true for Native Americans and Black residents. Research suggests systemic racism is often at play, and a legacy of discrimination in the medical system deters some BIPOC populations from seeking care. So a program we want to highlight, Colorado Access is supporting one solution to these high rates of maternal mortality, and that's with doulas. So Colorado Access has a new partnership between Mama Bird Doula Service, which connects Black Coloradans with Medicaid with doulas of color. Through the relationship with doulas, the program helps recognize other health-related social needs stemming from the systemic disparities these individuals have experienced. So standardized race data received from the Medicaid enrollment forms was utilized as a primary indicator and identifier for participants in this program. We know that stratifying data in this way can still miss all eligible members who could benefit from this program. Ultimately, this program contributes to the ongoing effort to combat systemic racism and healthcare discrimination by pairing a doula with a mother who can serve as a secondary advocate that is culturally responsive to their care. Colorado Access remains committed to continuing this initiative in order to reach more individuals and continue making strides towards equity in maternal health care. So again, another highlight, accurate patient and member identity can influence treatment outcomes, reduce healthcare costs, and advance healthcare equity and quality. There are two studies that we're highlighting here that have shown this. So the first study uncovered that a lack of representation compromises generalizability of clinical research findings to the US population. So findings suggested that improved representation of diverse identities within clinical trials. This underrepresentation is compounding health disparities with serious consequences for underrepresented groups. So lack of representation in studies means research findings aren't fully applicable to the entire population. So this reduces treatment effectiveness, naturally, which increases costs because findings can't be generalized to the population that weren't represented in the trials. Treatment effectiveness might not be the same across all those populations. By increasing representation in studies, treatments become more effective, yielding better results for individuals and reducing overall healthcare costs. So the second study we want to highlight is it found that race and ethnicity were often inaccurately recorded in an electronic health record for patients who self-identify as minorities, thus leading to underrepresentation of minorities in electronic health records. This is particularly noticeable among individuals who self-identified as Hispanic based on this study. This underrepresentation or misrepresentation in the electronic health system could notably impact research on disparities, the formulation of health policies, and both diagnosis and appropriate treatment. So looking ahead, there is a growing conversation, both nationally and locally, about expanding and standardizing diversity data beyond traditional race and ethnicity categories, which we're excited about. There are movements and proposals aimed at not only broadening these categories, but also eliminating the other option and promoting consistent data collection practices across various surveys and agencies. Additionally, we'd like to shout out the Colorado Health Institute's Colorado Health Access Survey, CHAS survey, stands as a notable example of expanded race and ethnicity categories. So this specific survey has demonstrated how such data disaggregation can influence health outcomes and survey results. And this has truly been a source of inspiration for us. And it is initially what prompted us to ask our race and ethnicity questions within our own member survey. So we didn't want to just share the data and our findings. We wanted to make some recommendations and take this one step further. So we emphasize the importance of enabling individuals, particularly Medicaid members, to self-report their identities as a powerful method of promoting social justice within healthcare. So by allowing individuals to self-identify their race, ethnicity, and culture, we're embracing authentic representation, ensuring that diverse identities are accurately portrayed and celebrated without resorting to harmful stereotypes. This approach not only preserves cultural heritage by recognizing and honoring diverse traditions and values, but also promote a deeper understanding among healthcare providers and patients, fostering mutual respect and appreciation. Additionally, enabling individuals to self-define their identities empowers them. It's instilling a sense of confidence and self-assurance. It demonstrates cultural responsiveness within healthcare settings, enhancing understanding through diverse perspectives and recognizing the complex intersectionality of human experiences. Most importantly, This practice amplifies voices that have historically been marginalized or overlooked within the healthcare system, contributing to broader justice efforts by raising awareness of systemic inequalities and actively working to address them. By embracing self-identification and promoting inclusivity, we're not just providing healthcare services, we're actively working towards a more just and equitable society. So our recommendations for entities collecting community demographic information include: first, enable. So we encourage self-reporting of patient and member identity whenever and wherever possible. Another suggestion is to improve the clarity of identification questions, potentially reducing ambiguity and thus improving accuracy in data gathering. Standardization is also beneficial, and we propose establishing consistent identity categories across public health organizations, promoting greater coherence in data interpretation. So this still means expanding categories and using those expanded options across large data collection entities so that reporting capabilities expand. We promote accurate demographic data sharing by acknowledging a connection between race, ethnicity, and health outcomes. We can advocate for informed decision-making. And lastly, strive to recognize that individuals belong to multiple demographic groups simultaneously. So, and public health efforts could take an intersectional approach. This means considering how various factors intersect and compound to create health disparities, rather than focusing solely on one race. So thank you everyone for your attention this afternoon. We want to open the floor for discussion and questions. We really welcome your insights, your feedback, and any questions you have.
Thank you so much for your presentation. Oh, it looks like we have a question. Ellen.
Hi, thank you for the presentation. So I'm very curious. I love the direction that you're describing. In the Latino Coalition, we work a lot with people who are in reentry and also victim services. And we have federal funders who obviously require us to report demographic data in their buckets. And so I think a challenge we've had internally is like crosswalking, because with our newer programs in particular, we're letting people, we're trying to open the gates for people to self-report and kind of crosswalking large data sets to what the feds require. I just wondered if there's any guidance. I'm looking at the CHI disaggregation stuff now, but do you have any guidance for how to do that and how to do that sensitively? Because we've had like disagreements among staff, like where certain self-reported categories go. I don't know, I would love to hear your thoughts on that. Thank you.
Sarah, could you share the appendix slide? I feel like that's a good example. This is a really good question and something that we have deliberated on for, for a long time. But
Yeah.
go ahead, Sarah.
Yeah, I was going to say this is exactly what every single person answered. And it was really hard to do what you're saying. And we just, the way we did it is if it didn't match what the enrollment form said, then we did not place them in that bucket or that match with the enrollment form. So it really had to be an exact match, or they were, they stayed as how they identified. And that's kind of what we landed with when we were doing this. But it is really hard to bucket people when the forms do not match how people are describing, for sure. Anything else to add, Lauren and Micah?
We are really validating that it's a hard science. I think one of the things we've found with our data collection methodology is including a lot of voices at the table, because we've had some people with lived experience be able to inform some of our practices in that way. It's also, it takes a lot of time and technical savviness, but disaggregating and then reaggregating probably feels pretty uncomfortable for given like that we want to really be able to promote individual identity. But I think for reporting purposes, we are still, we still adhere to the requirements that we're at. But we too, I was actually just this morning in a HEDIS audit where we have to aggregate our data, but our HEDIS auditor was asking for different data sources for race and ethnicity. And because of restrictions, they might not be able to go into our HEDIS data, but we hold them in different places within our EDW, within our data warehouses, so that we can use them for programming, even if we can't use them for federal reporting. Thank you. Wavine, what's next?
Let's turn over to June, who's had her hands up, and then we'll go to the questions in the chat.
Hi, everyone. I don't have a question, but really just wanted to congratulate you on this great work. I'm with HHS Region 8. I'm the Regional Minority Health Analyst. So this topic comes up quite a bit in my role, supporting states and organizations. I love that you're talking about this topic and sharing your work because it's so important, especially since data disaggregation is a huge tool that we can use for health equity. There has been changes in the OMB race ethnicity guidelines, as I'm sure you're aware. So if there's any support I can give in the future, I would love to do that. And this is extended to everyone on here too. Ellen, your question about where you would put self-reported race, ethnicity into different categories and where that would go. In my own work, I've really relied heavily on going back to community and asking, right, like, where should this go? And I think oftentimes we'd be surprised at the nuance that's involved in self-reported identity and then categorization, aggregation. So again, just wanted to really applaud you and thanks for talking about this.
Thank you.
Thank you. Yeah, definitely great comments and questions so far. And the revisions in the OMB is something that we're definitely aware of and working closely with HCPF too, to as we think about how the First Health Colorado can be more equitable. So with that, I'll turn over to the chat with questions. I would also love to follow up with you, June. So thank you for making yourself available in that way. Question from Rebecca. I have always wondered, let's see, something. Oh, why are there only two options for ethnicity, Hispanic and non-Hispanic? Can you speak to this? Also, does self-reporting contribute to ambiguity in data collection? Looks like you've answered that, Micah.
It's really just a systemic, it's, I think, based on old systems of data collection. I think my knowledge of it, and invite anyone else to do so. I think the ambiguity piece, and maybe you can speak more about it, or Lauren and Sarah can answer. I think it definitely, so the disaggregation separates populations and perhaps doesn't allow us to generalize as much, but I think that that's where we look at more individuals and look at individuating symptoms, individuating circumstances, and really take a person-centered approach. Sometimes that's challenging when we're talking about population health, but I think that's why we have brilliant data scientists who can re-aggregate data based on multifaceted approaches as opposed to sort of stereotypical race and ethnicity. Lauren and Sarah, what would you add?
You said that perfectly, Micah. So I have nothing to add.
Thank you very much. Yeah.
Awesome. And yeah, I would concur that my understanding is that the race or the Hispanic, non-Hispanic is very much old colloquialism and outdated is all it is. So next question in the chat I'm seeing is, have you had any discussion on collecting tribal affiliation for American Indian, Alaskan Native members?
So our survey, so I think yes, and I think we would be able to better connect you to the folks in our organization that are having those conversations in a broader scope, you know, with the state and with the social health information exchange. I think that's where those conversations are happening. Would
Within
you all add
our,
anything?
yeah, I was just gonna say within our data collection, if an individual had identified to that granularity, we would have documented it.
Yeah.
So for our sample, that didn't come up, but I think if it had, we would have documented it with the same granularity.
Right. I think those are the only questions I've identified so far in the chat. Are there any other folks here wanting to drop a question, go off mute? Feel free. We have about a couple more minutes before I'll round out this session.
I see Oak's question there. Was there a standard explanation which was provided to respondents if they asked why were they being asked these questions? Yes, 100%. We totally anticipated that they were going to be like, why are you even asking me these questions when I've just called into customer service for help for something entirely different and non-related to this? And so, yes, we prepped our customer service team pretty heavily with within the survey having like a nice response on why we were asking these questions.
And the customer service team really, we try to give them as much of a voice as possible to create this survey with us. So it's a co-creation and they feel really comfortable asking the questions as well. And because of that, I think they, you know, were pretty comfortable around the explanation piece as well.
Awesome. Hitting it up. Oh, Rebecca.
Yeah, thank you. I just thought of another question. So I work for Head Start and Early Head Start, and we have very standardized forms on race and ethnicity. And very often when we're enrolling a new client, they'll say something like, well, I'm Hispanic, I'm not white. And we've been told that if that comes up, we just automatically tick white. So I'm wondering if you have any suggestions on how to, because this is a larger issue, you know, how to promote changes in the way that this information is captured when it's out of our control. Like, what are some mechanisms that you would recommend? Because honestly, I feel like we're disrespecting the individual when we're choosing for them when they're disagreeing. Thank you.
Yeah, I think probably most, if not all, I would generalize relate to that tension and struggle. It is hard when our reporting capabilities are limited or structured based on requirements to get paid, as well as standardized forms. You know, it can be triggering and even traumatizing. If I were to make a recommendation, I think what we've seen is to open up options and to at least have a free text field where individuals can self-report. There are other issues around that with like data standardization or back-end data collection, but I think that's the other way. The other recommendation, Lauren, you had an example of this, is around a day-to-day basis. So when individuals come in, if you're client-facing or member-facing, to be able to ask some of those questions in a way that's asking, like, how would you like to be referred to? Similarly with other identity factors, to be able to say, you know, to which group do you identify, or are you aligned with any other cultural or heritage that you want me to know about? I think it also brings up the idea that it evolves, like that intersectionality means that like we also evolve. So if I went to a doctor 5 years ago and I had reported something, it may have evolved. So the invitation is to also understand and be open to the evolution of our race, ethnicity, evolution of how we identify.
That's very helpful. Thank you so much.
I think we have time for one more question. Anyone interested in asking? I'm going to make sure I didn't miss anything else in the chat.
I do have a question.
What?
If there's nobody else, I just didn't want to take up a lot of space. So, moving forward, how is the team planning on handling data for those who identify with multiple ethnicities?
I think this is something we've been talking a lot about internally. You know, what's received on enrollment forms federally that's kind of a separate level that's being worked on at higher levels right now, but there's still better ways that we could expand our data, I think, internally. And something I think we'd like to do is kind of break down that 2+ race category. I think that is an opportunity for us that we've identified, and we'd love to explore more. So that's definitely a next step for our organization there. I'm not sure, Lauren, Micah, if you have anything to add.
I was just gonna say, you know, we've given recommendations to Health First Colorado, who really controls this. So we have been working closely with them, and they really know how we feel. And they've been, you know, complete supporters of the process too. But as everyone knows, it takes a lot of time to change policy.
Yeah, absolutely. And if I may jump in, I also work with Colorado Access. I'm in the population health team, and we oversee health programming. And so part of what we can also do with this is use it to inform outreach and programming efforts. And so I think just having that granular level of information and the membership that we're outreaching and who we're not, and how they identify is informative, and I'm speaking, kind of using this data to inform programming as opposed to living in the data structure world itself and the survey structures itself. But we can still take that information and do something with it in terms of how we outreach, how we tailor programming, because it does say enough for us to ensure that we're kind of closing the gap. And so that is one way also that we like to use that information. As Lauren said, and as the whole team said, HCPUF is currently revising their application, and there are OMB, new OMB standards, which have that they're using to inform their decisions. We've also been working with them closely, and so it's a long haul game, but a lot of this work has been very instrumental and informative to ensure that we're not perpetuating racial and ethnic disparities through our data alone. So thank you so much, June, for your questions and comments. Really appreciate your participation. And yes, with that, I would love to close us out and want to thank you all for attending this session and engaging in the question and answer section. Q&A. And definitely thank you to our speakers, Micah, Sarah, Lauren. It is humbling to work with you all. It's just amazing the work that you do and the work that your team does. Quality improvement is really leading the charge in a lot of ways and within Colorado Access. So it's just amazing to be a part of and bear witness to the work that you do. So with that said, slides and any additional handouts that the speakers have provided are available in Sched. You will receive a conference evaluation via email after the conference is over tomorrow. Please fill that out, even if you've only attended a portion of the conference. It is very helpful for our planning committee. We do use your feedback to inform next year's events. There will be a raffle for everyone who completes the survey within the first 2 weeks, and you will get one of two $50 gift cards. So please go ahead and fill those out. Again, thank you. We will now have a 15-minute break before the day one debrief session. So there is a debrief session that'll go from 3:30 to 4:30, where we'll have some casual networking and fun trivia. So be on the lookout for that, and please feel free to join that event. We will pick back up tomorrow morning at 8:45 for the Emerging Leaders Showcase, which features 3 presentations from rising stars in public health on the topics of equity and data, a new tool to support the 2S LGBTQIA+ data autonomy, and advancing health equity through community partnerships. We hope to see you there, and for breakout sessions that will follow through 2:15 p.m. tomorrow. Please see the full schedule on Sched. And again, thank you so much for attending today's series of workshops or sessions. Really appreciate you all and your involvement. Thank you.